hypothalamus release the hormone, the cortisol releasing hormone, and this hormone act on the anterior pituitary gland to secrete ACTH, adrenocorticotropic hormone. This adrenocorticotropic hormone act on the adrenal cortex, that is the outer layer of the adrenal cortex, which release cortisol. Cortisol and ACTH both has a negative and positive feedback on the cortisol releasing CRH from the hypothalamus. So in this hormone secretion and inhibition is regulated. Now the causes of hypercortisolism. The causes are divided into two major categories, that is ACTH dependent Cushing's and ACTH independent Cushing's. The ACTH dependent Cushing, that is due to the ACTH hypersecretion, it is called Cushing's disease, that is ACTH production in the pituitary adenoma or from the ectopic area, that is, outside the pituitary gland, the ectopic source of ACTH. So in ACTH dependent, ACTH level is high. So the causes of ACTH, most common cause is small cell lung cancer, that is more than 50% cases, but other causes are also, that is thymic carcinoid, islet cell tumors, bronchial carcinoid, other carcinoid, and pheochromocytoma. Then the ACTH independent Cushing, that is adrenocortical adenoma, adrenocortical carcinoma, that is adrenal gland involvement. The tumor in adrenal gland causing excessive secretion of the cortisol, that is adenoma, or very rarely it might be carcinoma of adrenal gland. So now the clinical features of Cushing syndrome. Basically, whole of the body is involved. We can say that as far as the obesity or body weight is increased, lemon on the stick. That is the truncal obesity is very important and salient features of the Cushing syndrome. That is the fat deposition in the head, the neck area, and the trunk, resulting in typical lemon on the stick appearance. So weight gain is important. This is called central obesity as well as round. Because of deposition of the fat in the face, there is rounded face, and fat of the fat is deposited in the back of the neck and upper part of the back. It's called buffalo hump and the central obesity. Then the skin involvement. Skin become thin, brittle, and facial plethora, and the easy bruisability. A small scratch or small trauma can lead to the bruising of the skin. And the stria in the, especially the axilla, the groin, and the anterior abdominal wall. There is a purplish broad stria, and the acne, hirsutism. These are the features of the Cushing syndrome. The bone involvement can also occur in the form of osteoporosis, osteopenia, vertebral fracture are very common in this disease. And the decreased linear growth in children. When children are affected with the Cushing syndrome or Cushing disease, the linear growth, that is a growth in height, is stunted. Then the muscular involvement, muscle become weak, especially the proximal muscle. Proximal muscle of the lower limb, the thigh, proximal muscle of the upper limb, that is the arms, are weakened and they are atrophied, resulting in difficulty to stand from the sitting position without support, or difficulty in combing on the hair, or elevating the head above the shoulder in the marked disease. The cardiovascular abnormality is very much common in Cushing syndrome. First of all, hypertension, edema, and peripheral edema, and atherosclerosis can also occur, because it not only involves the glucose metabolism, but also it involves the lipid metabolism, resulting in atherosclerosis and there might be myocardial infarction, and severe stroke can occur in such patients. And metabolic abnormality is that because the cortisol is anti-insulin hormone, insulin antagonist, it increases the glucose. It causes the formation of glucose, increase production of glucose, resulting in the glucose intolerance and might lead to the diabetes mellitus and dyslipidemia and hypokalemia. Very important, hypokalemia, because cortisol uh, also has a mineralocorticoid effect. It causes sodium reabsorption and the simultaneously potassium excretion. So more potassium is when excess cortisol, excess mineralocorticoid activity, more potassium is excreted out and resulting in hypokalemia. Then on reproductive system, it causes a decrease in the libido and the menstrual abnormality in females, that is amenorrhea. As far as the CNS, central nervous system, is involved, there might be the irritability, the confusion, depression, cognitive defect. Patient might be in the psychotic state in marked Cushing syndrome. And the blood and immune system involvement, increased susceptibility to infection, increased WBC, eosinophils, hypercoagulability with the increased risk of DVT and pulmonary embolism. So these are the effect on the blood and immune system. So this diagram shows the whole of the full brawn features of the Cushing syndrome. There you can see the pendulous abdomen with the stria and the thin lower limbs and upper limb, and the trunk is also enlarged. That is, trunk is fatty. That is central obesity as well as a deposition of the fat in the trunk. That is a fat pad, buffalo hump, and the thin skin, and the poor wound heal, and the osteoporosis, which might lead to the avascular necrosis of the bone and the fracture of the neck of the bone, as well as fracture of the vertebrae, and the vertebral collapse can occur. So this is a multi-system organ involvement in Cushing syndrome. Similarly, when we go from upward to downward, these clinical features are pronounced in the Cushing syndrome, which are, for example, when we look at the brain, the emotional disturbances, okay, then the enlarged cella turcica can occur if the pituitary adenoma causing pressure effect or large pituitary adenoma. Moon phase, osteoporosis, cardiac hypertrophy lead to the hypertension, buffalo hump, obesity, adrenal tumor or hyperplasia, thin wrinkled skin, abdominal stria, the amenorrhea, the muscle weakness. As I said earlier, the proximal muscle weakness is very much pronounced in Cushing syndrome, and the skin and ulcers and the wound difficult to heal wound, and it takes time. So these are the features of the Cushing syndrome. So facial plethora, moon faces of the both person with facial plethora. This is a typical Cushing-White face. These are typical purplish, stretched, marked on the anterior abdominal wall stria, which are pathognomonic of the Cushing syndrome. Hirsutism, there is an excessive hair growth on the face, as well as acne, are also features of the Cushing syndrome. As I said earlier, thin and brittle skin, hyperpigmentation of the knuckles. That is these are the knuckles. Hyperpigmentation of the knuckles can occur. So, as far as the complications of the Cushing syndrome is concerned, that is, if Cushing syndrome is not diagnosed on time, and untreated, then there are the complications. The complications are the diabetes mellitus, the hypertension, high blood pressure, the osteoporotic fracture and avascular necrosis of the bone, easy tendency to infection, multiple infection can occur, where severe sepsis can occur in such patient. Nephrolithiasis can be occur, psychosis, then the differential diagnosis. So we can differentiate from the alcoholism because few features are also are similar like the obesity uh, and the proximal muscle weakness and different features. With alcoholism, we can differentiate by means of history as well as the clinical test. Then anorexia nervosa, it can be differentiated by high urinary free cortisol level, familial cortisol resistance. So these are the three very important differential diagnoses, but these two are rare. I don't want to go into detail of two rare differentials. Then the diagnostic test. Diagnostic test is first screening test, very important. The overnight dexamethasone suppression test. First of all, I tell you the concept of the suppression test or stimulation test. In the endocrinology, when the hormone are secreted in excess in high amount, then we used the suppression test. When the hormone is not secreted, that is secretion is in low amount or hormone function is reduced, we use stimulation test. For example, one of the example of stimulation test is ACTH stimulation test, which is used for the diagnosis of Addison's disease. So, but in Cushing syndrome, because hormone is secreted in excess quantity, so we have to use suppression test. We give the same hormone externally and look at the suppression. So, two screening tests: the overnight dexamethasone suppression test for 24-hour urinary free cortisol. These are the screening tests. We screen if we are suspecting the Cushing syndrome, clinical features of Cushing syndromes are there. Then first of all, we screen such patient. Screening tests are these two are the screening tests which is commonly used. Then the other tests which can be used are the midnight serum cortisol, that is more than 7.5 is the diagnostic, the screening test positive. Midnight salivary cortisol more than 0.25 is specific sensitive for 93%. Now the false positive, these tests may be false positive in when there is morbid obesity, that is a BMI more than 35-40. Estrogen, when there is an estrogen, patient is having the pregnancy or taking an oral contraceptive pill. So 24-hour free cortisol, urinary cortisol, and overnight dexamethasone can be falsely positive in such situation. The phenytoin, the phenobarbital, or rifampin, these drugs accelerate the metabolism of dexamethasone, resulting in the false positive screening test. Severe stress, severe depression. Now the confirmatory test, very important. After screening test, we go to the confirmatory test. Low dose dexamethasone suppression test. How can it perform? Dexamethasone 0.5 milligram 6 hourly giving 48 hour. That is prior to taking the sample, 48 hour prior to taking the sample, that 2 days, we start dexamethasone 0.5 milligram 6 hourly for 48 hours. Then measure the urinary cortisol during the last 24 hours, the second day, or plasma cortisol after 48 hours. Interpretation: urinary cortisol less than 100 or plasma content less than 60 nanomole, exclude the Cushing syndrome. That is, person doesn't have the Cushing syndrome when the urinary cortisol less than 100 and plasma cortisol less than 60. So this shows the Cushing syndrome is not there. If more than 100 urinary cortisol and the plasma cortisol more than 60, this is the confirmed that the patient have the Cushing's syndrome. Then the second step is the ACTH level is very important. It distinguishes from the Cushing disease and the Cushing syndrome and ectopic source as well as. So ACTH level may distinguish the ACTH independent, that is adrenal or exogenous corticosteroid, from ACTH dependent pituitary ectopic ACTH. ACTH independent, in the ACTH independent, ACTH level, adrenocorticotropic level is low or undetectable. Either the ACTH level is low than the normal or undetectable. This shows that patient might have the ACTH independent adrenal oriented adrenal adenoma, or patient have the exogenous corticosteroid intake resulting in Cushing syndrome. While in ACTH dependent, ACTH level is high, and moreover in ectopic ACTH source, that is the ectopic secretion of ACTH is 8 times higher than the pituitary ACTH adenoma. Now the imaging. We established the diagnosis, first is screening, then diagnosis, then we go to the imaging to localize the source of the tumor. First image, that is MRI of the pituitary, demonstrate pituitary lesion in 50% of the cases. When the pituitary MRI is normal or shows a tiny less than 5 millimeter diameter irregularity, that is a suspicion, not the clear diagnosis, then selective catheterization of inferior petrosal sinus, venous sinus drainage of the pituitary and for drain, and then check the level of the hormone. In ACTH independent, the Cushing's syndrome, that is adrenal, CT of the adrenals usually detected a mass lesion. Most of the lesions are benign adrenal adenomas. Few are adrenal carcinoma. So carcinoma is very rare. Most of the lesions are either adrenal hyperplasia or commonly adrenal adenomas. So this MRI pituitary shows clear-cut arrow shows this is the enlarged pituitary showing pituitary adenoma. These are the enlarged adrenal glands, adrenal adenomas. Then the very important thing now is the treatment. Treatment of first choice is localization of tumor and surgical excision of the tumor. In case of Cushing disease, usually there is a microadenoma of the pituitary gland secreting excessive ACTH. So transsphenoidal resection of the pituitary adenoma. Previously we used the transfrontal, transcranial, now very specific, that is transsphenoidal. Easily reach the pituitary fossa by nasal route, and a pituitary gland is behind the nasal septum. That is a sphenoidal bone. Then in adrenal involvement, adrenal tumor or neoplasm, resection of the either tumor or adrenal gland. Ectopic source is very difficult to localize. If we localize the ectopic source, we can remove the ectopic source by surgical means, if possible. Then in few cases, bilateral adrenal hyperplasia may need adrenalectomy, because the adrenalectomy there is an absolute deficiency of hormone. So lifelong corticosteroid cortical replacement is required in such situation, which is and monitoring lifelong. Then medical treatment. In the medical treatment, we have these list of the medication which we can use when the patient surgery is contraindicated to the patient, for normalizing the cortisol level prior to the surgery so that we can stabilize the patient, or when the recurrence of the tumor after surgery. So these are the treatment options. We can also say that the treatment options are medical adrenalectomy, that is ketoconazole dose antifungal. Dose is 600 to 1200 milligram per day. Metyrapone 2 to 3 gram per day. Mitotans 2 to 3 gram per day. Aminoglutamide octreotide can work in 1/3 of the patient. The major side effect is adrenal insufficiency. Therefore, start at lowest dose and titrate. So this is all about your topic, that is the causes, the etiology, the clinical features, the diagnosis, and the management of the Cushing syndrome. Now I invite you all for any question regarding today's class, because I have completed this is the last slide. Any question from your side? Always आवाज आ रही?
जी सर, आ रही है आवाज, आ रही है, बिल्कुल सही आ रही है.
Students, any student who want to on any question?
सर वो चैटिंग में करेंगे, चैट का ऑप्शन ऑन कर लें आप अपना मोर में जाके.
चैट का, अच्छा.
हाँ, मोर लिखा हो ना, मोर में खोलेंगे ना चैट. हाँ, उसको चैट को क्लिक करेंगे, चैट का बॉक्स आ जाएगा, वो साइड में रख ले, उसमें क्वेश्चन आंसर रहेंगे.
चैट बॉक्स कैसे होगा यार, मुश्किल हो रही है बहुत.
सर मोर लिखा हुआ है ऊपर.
मोर का लिखा है, ये लिखा हुआ है नीचे. हाँ जी,
उसको खोलेंगे ना.
हाँ,
चैट बॉक्स आ
गया. अच्छा, मोर, अच्छा, चैट बॉक्स. ओके,
ठीक है सर,
चैट बॉक्स आ गया. Students, any question regarding this very important topic? And there are a lot of questions in your exam comes from this topic. Not only as far as theory is concerned is important, but practically it is very important. Any question from your side? Anybody?
जी सर, कोई क्वेश्चन नहीं है.
अच्छा, फिर सही है. ओके, अब क्लोज करते हैं, इंशाल्लाह नेक्स्ट लेक्चर में मुलाकात होती है. ठीक है, सही है. ओके, थैंक यू.
अल्लाह हाफिज़.
थैंक यू. अल्लाह हाफिज़.